Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi, my name is Mike Sullivan, and I'm one of the instructors at Valor Medical Services. In this program, we'll be discussing congestive heart failure. Now, the National Registry has two key objectives they've outlined for this program. First off, we'll discuss congestive heart failure and identify it. Secondly, we'll analyze the appropriate and inappropriate treatments and how we can manage it in the field. Before we get too far, what is actually CHF or congestive heart failure? Well, at the simplest level, it's the failure of the heart to adequately pump blood, thus allowing fluid to back up. Typically, the fluid will affect the lungs or the peripheral circulation, depending on which part of the heart is involved. Now, the presentations we'll see from patients will vary based on, again, what part of the heart is involved. So, if we're looking at a heart failure that is predominantly left-sided, meaning the left ventricle and the left atria, we'll see pulmonary edema, crackles, rales, fluid backing up in the lungs. We'll see diminished bilateral breath sounds. We'll see diminished tidal volume. If the patient's lungs are 25 or 35% full of fluid, it will significantly decrease their tidal volume and their ability to move air. We may see hyper or hypotension with this, especially if the heart failure on the left side is significant and has damage to the left ventricle. It may not pump as well as it used to, and so therefore hypotension may become very normal. It may also eventually present with some of the right-sided issues because, as we know, heart failure backing up from the left-hand side may back up to the right-hand side. Now, let's say our failure is on the right side due to damage to the right side from, again, infarct or trauma, something else. This will lead to peripheral edema, maybe in the lower extremities, maybe a sacral edema if the patient is bed confined, as that would be their lowest point where fluid could pool. We may also see JVD or jugular venous distension due to fluid backing up into the circular system. Now, why is the difference between the two of these? Well, if we think back to the basic anatomy of the heart and the path of blood through the heart, if there's a problem on the left side and blood starts backing up, that blood's going to back up and sit stagnant in the pulmonary system. So therefore, it's more likely to seep out through there. On the other side of the coin, if blood is backing up on the right side of the heart due to right-sided damage, it will back up through the right atria and back to the inferior and superior vena cava, which will typically affect more the periphery than it will the lungs. So largely the patient's presentation is based on which side of their heart is weak or which side of their heart's not adequately pumping. So now when we look at some of the common causes of pulmonary edema or congestive heart failure. First off, a pump problem is the most common. The patient may have a previous heart attack that's done damage to part of their heart muscle. There may be ventricular damage from other causes such as trauma, infection, long-term pericarditis. There may be a congenital issue. It could be cardiomegaly or hypertrophy. There could be a pipes problem or a problem with the vasculature. This could be caused by increased peripheral vascular resistance, i.e. the peripheral vasculature is clamping down and thus squeezing the excess fluid has got to go somewhere, and it starts to find places in the tissue to go. It can be chronic COPD. It can be a fluid-based problem. Perhaps the patient's fluid overloaded. There could be renal insufficiency, whether they have not taken enough fluid off at dialysis, the patient missed dialysis, or the patient didn't adequately monitor their fluid intake. If we think about dialysis patients, they have to get fluid taken off every other day or every third day usually. Well, if they miss a day or miss 2 days, or they're not maintaining their diet and their fluid intake properly, excess fluid in the system has to go somewhere. It could be non-compliance with medications. In some cases, we'll see patients who are supposed to be on diuretics. They may run out of a medication or forget to take them, or some patients deliberately don't take them because they don't like to pee all the time. Well, unfortunately, they've gotten rid of that medicine that made them pee all the time, and that may be very convenient, but that medicine was doing it to get rid of excess fluid. So now what happens? The fluid is overloaded, and the overflow and overload has to go somewhere. So now when we're faced with a CHF patient, how do we handle it? Well, there's a few tools we can use beyond just the basic ABCs. One of the first ones we'll talk about is CPAP, or continuous positive airway pressure. This has been one of the biggest advents in EMS care in the last, I'd say 15 or more years. The reason is we're using CPAP, positive end expiratory pressure based on PEEP, to actually force air into the system and help keep the alveoli open, forcing the fluid out of the alveoli, trying to force it back to where it belongs in circulation. We're saying, look, we want to evict this fluid out of the lungs and get it back into the vasculature. Now, it works fairly quickly and works fairly easily and doesn't require a lot of skill to actually get in place. In many cases, this can be accomplished without even having to have an IV established. However, the downside is we may have to heavily coach the patient to have them tolerate it. If you look at the mask in the picture there, if the patient's already having trouble breathing, feels like they're drowning, and is gasping for their last breath, they may not be all gung-ho about you strapping that mask to their face. Unlike a regular oxygen mask, this mask is much heavier. It's got a rubber cushion around it designed to make a seal, much more like the mask you'd see attached to a bag valve mask. So once it makes that seal, it's going to push continuous pressure, PEEP, into the patient's lungs to help open them up and help to push the fluid out. The problem is, if that patient's already in panic mode, they're not going to want you strapping anything to their face, especially if it feels like they're already drowning. So this may take a lot of coaching. You may have to get the patient, to sort of cooperate with you, to have them tolerate it. One thing you can try to do is get them to hold the mask for themselves to their face and try to get 3 or 4 or 5 good breaths. By trying to do that, once they feel that yes, they're getting plenty of airflow in through that, and there may actually be 100% oxygen to begin with, that will make life a lot easier for you, because at this point they may decide they'll tolerate it better. So, while CPAP is great, it can also pretty much require that one of our providers in the truck almost has to be one-on-one coaching the patient until we can get them to tolerate it on their own. Now, there's a few times that CPAP isn't really a great choice. First off, if the patient is unable to maintain their own airway. CPAP won't actually hold their airway open or protect their airway, and if they're unable to maintain their own airway, they're not really a candidate for CPAP. We'd be looking more for a bag valve mask or some type of secondary airway management. If the patient's unable to maintain their own respiratory rate or their own ventilatory rate, we'd need to definitely go ahead and start assisting them with a BVM and consider other airway adjuncts. If the patient has significant hypotension, if the patient's had recent esophageal surgery, remember CPAP works by holding continuous airway pressure behind the fluid to try to push it out. If the patient's had recent esophageal surgery or a history of esophageal varices, they may not be a very good candidate for it. By that same token, possible pneumothorax or a recent pneumothorax. Both of these, we would not want to put the excess pressure in the airway system, as we would not want to cause another pneumothorax. And lastly, like I said before, if the patient's unable to tolerate the mask. I will say, in many cases, we can try a brief trial of CPAP to see if we can get them to tolerate the mask, and if they won't do it, it can potentially buy us some time to start working on something else or an alternate plan. On the other side of that coin, some patients who have had CPAP before, especially in response to CHF issues or fluid pulmonary edema issues, we've seen some patients are very gung-ho about the mask, and they'll ask for it by name, because once they realize how well it works and how quickly it can make their breathing easier and how rapidly it'll fix them, they're their new best friend. So when we get into nitroglycerin, now nitroglycerin a lot of us know about for chest pain. However, in this setting, we're using it for its vasodilation properties, trying to not only decrease myocardial oxygen demand by dilating the arteries, but also trying to make the vasculature and the vascular container bigger. We're trying to find a better place for fluid to go beside the lungs, because we know we need to open up the lungs and we need to get the fluid out, and so we're going to try to push it from one side with our CPAP, maintaining our continuous pressure, but from the other side we want to actually open up the container to make room for it to go. So yes, we're going to push it from one side, but it's much easier to push a car downhill, so we want to drop that pressure down, pressure gradient, and get it across. Now, nitroglycerin is available in several different formulations and designs. It may be administered sublingual, which may be our most common for our cardiac patients or chest pain ACS patients. In many cases, for CPAP or for CHF, we'll use a transdermal nitro, such as the one pictured there, where we do 1 inch to 1.5 inches nitro paste, and that will actually be a much steadier long-term administration, and in addition, it won't require us to break the seal on the CPAP mask repeatedly to get our next nitro dose in. Another option that may be available in some locations or in a critical care setting is nitroglycerin drips. Now, if you are in an agency that uses nitro drips, either for transport purposes or for field responses, please make sure you use appropriate nitroglycerin tubing, non-PVC tubing. PVC tubing can be eaten up and damaged by nitroglycerin, which will leach through it. So in the perfect world, we'll avoid using any PVC-based tubing anytime we're running a nitroglycerin drip. Now, there's a few contraindications to nitroglycerin. If the patient is already hypotensive, if the patient has used any of these ED meds within the last 48 hours, Now, I know some systems use 48 hours for certain meds and 24 to 36 for others. As a general rule of thumb, I try not to give any nitroglycerin within 48 hours of any of those medications. Now, that does not mean if we have to, and I know it's one of the meds that is typically shorter acting, it also doesn't mean I can't contact my med control doc and say, okay, the patient took this, but it was so many hours ago. It was Viagra, and it was 36 hours ago. And they may say, okay, Viagra, you could be safe at 36, but that new long-term Levitra CR controlled release, we probably have to wait 48 hours on it. So again, be aware of that, and also be aware, I've listed 3 of the names there, but we probably have some other ones we need to watch out for. So as things come out on the market, be wary about, will this mix or will this react with nitroglycerin? Now, we also have Lasix or furosemide. Now, when we're managing it with Lasix or furosemide, we know that Lasix is a loop diuretic. It works in the kidneys to increase urinary output. Now, this is going to typically begin about 30 so minutes after we administer it IV. Now, the first round of effects we'll see from Lasix is mild vasodilation that may begin in 5 to 10 minutes. So if IV Lasix will start working in maybe 5 to 10 minutes, and Lasix as far as diuretic starts working in 30 minutes, now you can see one of the biggest advantages of CPAP. Now, Lasix or furosemide may be a home med administered by mouth. It may have sometimes EMS carrying it or an ED carrying it. And for many years it was the centerpiece of care for all things CHF. However, things changed in the last several years. This is a very potent diuretic. So if we're giving it, it's going to make patients urinate a great deal. Now, while this is great to get rid of their excess fluid, it can present us a couple of problems. So it's sort of fallen a little bit out of the favor with EMS treatment, not 100%, and it's not necessarily that this is bad, it's just not as effective as CPAP. One of the biggest concerns we have is the increased urinary output may cause electrolyte derangements, specifically hyper or hypokalemia and hyper or hyponatremia. So, if we have a patient that we've given a large amount of Lasix to, we know that that patient, when they start urinating excessively, they're going to need to watch their labs and watch their electrolyte levels. This typically is going to border into an ICU admit. So, from that standpoint, many times the concept of doing no further harm, it's better to try to manage with CPAP and or nitroglycerin than it is a big slug of Lasix. Now, some other options that are out there, nebulizer treatments. Now, while we think of these mostly in conjunction with asthma, it can help not only open the upper airways, but it can help open the alveoli and increase air exchange. Another option is positive pressure ventilation or assisted ventilations. Now, this is good because A, the positive pressure from our ventilations, while it's not as helpful as CPAP would be, it can still help significantly as far as trying to push the fluid back out of the lungs. Also, even if the patient is breathing, we can still assist ventilations, and that would help them get more air in, increase their tidal volume, and have a better respiratory rate. Patients may appreciate this if they're extremely tired and they've been struggling to breathe for hours. So in closing, while CHF can start and originate in a lot of different ways, the end result is it's going to typically cause significant respiratory compromise or peripheral edema. CPAP is an excellent modality, but it can be very provider intensive to deploy. Strongly suggest if you're going to try to CPAP a patient who's in acute distress, one provider sit there and be coaching the patient through it, because otherwise, likely unless the patient's had it before, you're not going to get them to keep the mask on, and the more they break the seal, the less effective it's going to be, and we may end up wasting more time with something that's not working. Nitroglycerin can be a wonderful adjunct to partner with your CPAP, very much so, because again, while CPAP we're using continuous pressure to push the fluid out, we'll use nitroglycerin to make room for it to go back in the vasculature. And Lasix, while it is still acceptable in the pre-hospital environment, it's getting much more limited use now that we're seeing better effects with CPAP and nitroglycerin. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.